that. These patients sometimes don't have to have the most perfect pathology in their eyes, and there's a little bit of range of what you can do with monovision. Mini monovision, sometimes doing plano and leaving somebody about a -125, or sometimes people like to push the envelope a little if they're really used to it. And so monovision is a great option for those who are comfortable. And then nowadays, people are coming in more and more, having educated themselves, reading a lot about ATIOLs, and there's so many options with EDOF lenses and even multifocal lenses. So another option, another popular option is putting in two EDOF lenses. This is great for people who really want their eyes working together and having good depth perception. And these are good. That's good for patients who really don't care as much about their near vision.
Yeah, I'm glad you brought that up. I kind of wanted to go a little deeper on discussing EDOF lenses because it seems like what's available allows us to correct for distance and intermediate, but with not as strong of a correction for near. So how do you go about counseling patients when you're trying to make this decision with them about balancing what kind of vision they're going to achieve and what they may need to wear eyeglasses for?
I think that's the absolute most important question, is trying to figure out what your patient wants. I spend a lot of time really getting to know my patient and figuring out what type of activities, what hobbies, what is their job, and what they're really using their eyes for. And similarly, I like to know what they're doing now before they have this correction. Are they wearing glasses for anything at all? And are they wearing contacts, and for what? So getting to know the patient is really, really helpful. If I have a patient that spends a lot of time up close and they're doing a lot of needlework and things like that, the EDOF lens might not be the best choice for them. Mm-hmm. But if I have a patient that's doing a lot of computer work or even a lot of distance work, that could be a great option.
Yeah. Let's shift gears for a moment and talk a little bit about post-refractive treatments, because these can be really sometimes challenging cataract cases, because a cataract surgery is sometimes not as predictable or as precise as a laser vision treatment in some scenarios. And in patients who have undergone prior laser vision correction, the cornea takes on a different shape and makes our IOL calculations a little difficult. So do you have any suggestions for the patient who is coming in, who is status post corneal refractive surgery, mm-hmm. and is interested in presbyopia correction? This is kind of a tough challenge to achieve.
This is a big patient population, mm-hmm. in my practice, and again, these are patients who have a lot of expectations for their vision. If they've had laser vision correction before, they're very, very interested in being glasses free a lot of the time. So counseling again is a big topic here, and trying to figure out, did they have both eyes for distance, or did they have a monovision with their laser vision correction? And I think going over all the options with them and explaining that it's not a perfect science, that there's some gray area here, they still tend to really be very reasonable in their selections. They can have options if their vision correction wasn't too big of an ablation, then a lot of times they can still be good candidates. Nowadays, for EDOF lenses or multifocal lenses, nowadays the calculations are so very, very good. We have all these people working on optimizing our different formulas and things, so you can get pretty close.
Yeah. Well, I'm glad that we were able to get to discuss that, because, as you know, our population of patients seeking cataract surgery is becoming a higher and higher percentage of people who have undergone refractive surgery. So this is super important.
I'm also seeing a whole lot of the RK patients who had RK back in the 80s come out of the woodwork. So that's another thing to look at, and a lot of times these patients are very particular about their vision too. So
yeah, and RK of course opens up a whole new ball game of refractive options that I don't think we have time to get into this morning. But Lena, I wanted to thank you for coming on the program. It's been a great discussion for us about how to approach presbyopia correction in cataract surgery. Thank you so much for sharing your expertise.
Thanks for having me. Appreciate it.